It's all in your head. You don't look sick. Your tests are normal. It's probably anxiety. There's nothing wrong with you. Have you heard these words from physicians, family, and friends? If you're someone who has been struggling and swirling through the revolving door of healthcare to find answers about your health, or if you know someone who is going through this experience, then this podcast is for you. Welcome to the Desperate for a Diagnosis podcast with Laura Nozica. Hello, and welcome to the Desperate for a Diagnosis podcast. I am your host, Laura Nozica, and I think that this episode offers some of the coolest opportunities to hear from one of the coolest ladies and physicians that I have met, who wrote a book, and she's done all kinds of other things too. But what's cool about her is that we've been talking a lot about the topic of patients feeling dismissed, which is really the premise of my podcast, talking about those hard to treat, hard to diagnose, hard to find a diagnosis for those mystery symptoms. Patients who have seen multiple physicians trying to get to a diagnosis, get resolution for their pain or whatever it might be. And I am here to introduce all of you to Dr. Joan Naidorf, who I am so excited to be talking with her today. And we'll talk about her book and the topics in her book. And I think what everyone will get out of this is just some understanding of what is going on the other side of healthcare. I think we all know that healthcare is very complicated. I think most of us would describe it as broken. And Dr. Naidorf gives us some perspective on what's going on the other side. So I like to say I like to get perspectives from both sides of the bedside. So we're going to get some of her perspective today from that standpoint. Let me introduce you to her, give you a little information about who Dr. Naidorf is, and we will get into it. Dr. Joan Naidorf is an emergency physician, author, and speaker located in Alexandria, Virginia. After retiring from 30 years in clinical practice, she wanted to teach more about improving the interactions of healthcare professionals and their patients. Changing How We Think About Difficult Patients, a guide for physicians and healthcare professionals, was her book published in 2020. She also reviews books for the DO magazine and serves on the editorial review board. Improving the experience for patients has become a recent subject of her speaking and writings in the Washington Post, on medium.com, and on her blog. She is the mother of 3 adult children and a very anxious miniature poodle named Dolly, who I met on our pre-chat, which was really fun. Dolly is an adorable little creature. So Dr. Naidorf, thank you so much for being here today.
I'm very happy to be here.
Yeah, thank you. And just so everyone knows, I came across Dr. Naidorf on medium.com. And if those of you aren't familiar with medium.com, you should check that out because it is a what would you call it? User-generated content website, doctor?
The platform where a lot of authors and other kind of experts and content creators, people who want to be writers, post their articles. For me, it's been an area to try to get a little bit more eyes viewing what I have to offer. For people who are not subscribers to medium.com, you get a few articles just by clicking on. But after that, you have to be a subscriber. But I also post all those articles on my own website, which we can, is at drjoannaidorf.com, and we can link in the show notes.
Yeah, for sure. So everyone should check out Medium if you haven't already. Really some interesting articles. And I know everyone's learning everything on YouTube and TikTok these days, but I will say I have learned a ton off of Medium, and I have written some articles for Medium as well. So everyone should go and check that out. So Dr. Naidorf, retirement means something different for you, I would say, because even though you're retired from clinical practice, you've had a lot going on and writing and traveling and doing all kinds of things. But
I love the fact that you wrote this book, Changing How We Think About Difficult Patients, and it's a guide for physicians and healthcare professionals. I have it right here. We're going to be referencing some thoughts and ideas and takeaways from Dr. Naidorf's book today. But tell me a little bit about why you decided to write this book. And it's so recent, and I'm sure you can tell us all about the oh so lovely, I'm sure rewarding though, process of writing a book. That's a whole nother story, right?
It is. Well, it came about in an interesting way. After I finished my training, and I trained in Philadelphia, I came to Northern Virginia and started my job as what we call an attending physician in a very large community hospital right outside Washington, D.C. And I really love my work in emergency medicine. However, I would find that there are certain aspects that were making me unhappy, or that led me to feel unhappy. And some of them were some of the difficult interactions with patients. And as a shorthand, doctors and nurses refer to these type of people as difficult patients. So at the time, I was clinical faculty with an emergency medicine residency program at George Washington University. And I researched the issue and gave a presentation called Dealing with Difficult Patients. And had been some kind of research into the problem. And I found one of the articles, I did a lot of the research, and a lot of the reading was in the kind of psychiatric literature, not in the literature of emergency medicine, which is a relatively new profession at the time that I started in it. I'm residency training in emergency medicine. And I tried to apply it to our patients. I gave it 1 year as a grand rounds lecture. My director liked it so much, he asked me to give it again the next year. And then I put it away and had 3 children in 2 years. And
Oh,
general craziness of,
wow.
I started out with twins. And when I kind of came to the end of my days as an emergency physician, I learned a lot, and I did get better at some of my difficult interactions by writing the book. I decided that I had the end of a career is a difficult thing, retirement, like you say. And I felt like I had some gas left in the tank, and I decided that I would kind of dig that out and revise it. And there were a lot of things I had learned, and a lot of ways that I had stumbled upon how to change your thoughts. Here you have a problem, and when the problem isn't going to really go away. I mean, difficult people with troubling diagnoses, people who don't speak our language, people who are not taking their medicines, people who are doing drugs, people who are drinking too much alcohol. All these people are going to come in. Some are going to be really angry or frustrated, outright violent. We're still going to have these problems, but the only thing to make it better was to change the way that I could make it better is to change the way that I was thinking about them. And I wanted to share this message. I dug up my notes, which were literally on pin-fed paper. Some of you will be old enough to remember what that was. And I expanded it, and I started giving that lecture to some emergency medicine residents and other at conferences around the state of Virginia. One of my friends suggested that I should write a book. And so I did a big think about that. And I decided to take the lecture and expand it into a book. I did not have the typical experience that most people have. I just happened to appear in another podcast at this time. I had started writing a few articles, and I asked the podcast host how he had gotten his book published. And he gave me the name of his publisher. I sent my manuscript, which is completed, to her, and she gave me a contract to publish the book. So this is not a typical experience. I did have to revise it because she wanted me, I had written it kind of for the emergency medicine patient and emergency medicine clinicians.
Mm-hmm.
She wanted me to expand it to kind of all medical settings. And a lot of people in other medical settings have responded to me since reading it, physical therapists, respiratory therapists, other parts of our profession, and we're really, it's a big team. We're all really important. It's not just physicians and nurses. That message is out there in the book. And I try to do some presentations like this one. The book is actually for medical professionals, but, strangely enough, other people come and tell me that they find it very useful. I mean, one of my nicest reviews on Amazon is from a middle school teacher.
Oh, wow.
The lessons that can be learned from it are applicable to
Uh-huh.
other professions.
Yeah, no, I get that. And I've gone through the book, and having worked in so many of the healthcare systems here in Chicago, I worked in a marketing capacity, but certainly was at the table with the physicians, with the C-suite, with the clinical directors, the operational folks over all of the service lines, et cetera, just to learn and understand the dynamics of what's going on so that I can be the good marketer. So much of this, I think, to this teacher's point, is about reframing how you view other people's issues, conflict resolution. I think there's a lot in here, and empathy. We talk about empathy, and I know you talked about empathy in the book as well. And so I could see where she would say that. Well, and I will be another one, doctor, who will be writing an Amazon review for you, because it really is a fantastic book. But what I would like to get into is really just jumping into what's considered that difficult patient and how doctors view a difficult patient. And what I think is interesting, and it's page 1 of the book, where you say, patients are problematic only when they evoke negative thoughts in the treating clinician, thoughts that create feelings of frustration, confusion, anxiety, sadness, and disgust. You cite a reference here, a study published in the Archives of Internal Medicine. And that study noted that physicians in an internal medicine practice rated approximately 15% of their patients as difficult. And the study showed that difficult patients tended to have depressive or anxiety disorder, poor functional status, unmet expectations, reduced satisfaction, and more frequent use of healthcare services. So knowing that, in this one statement here that I do appreciate, difficult patients raise the gamut of negative feelings within the clinician toward not only the patients, but also toward themselves, which I think is really interesting, that sometimes we don't always think that physicians take this inward check, kind of self-check on themselves when it comes to dealing with patients. So describe more about that. What's going on the inside at that, in that type of circumstance?
The interaction between a physician and a patient is very complex interaction that's occurring between two humans. And what I would say is that, and I'm going to speak mainly about my own experience in the emergency department.
Please, yeah.
And I use the term emergency department, not emergency room. That was what we were taught on the first day of emergency medicine residency. And our primary focus is to try and get you better, trying to make a diagnosis and to get you out of the emergency department, which sounds crass, but it's very important because we have a lot of people waiting for the service. We can't lollygag around for as long as possible to let people get better. At one time, when I was a very young physician, we could let people kind of sleep it off. We don't have that luxury anymore. People are clamoring for the beds. And it's very hard to get people admitted. People have to be, if there's some condition that someone has that we feel that they can be given some medication and go home with and have the same or as good an outcome, it's not that we want to send them home. We just have to send them home because there's no way to get everyone admitted who 30, 40 years ago might have been able to get admitted. So have a time constraint. People are waiting for us. I know doctors in an office have only a certain amount of time that they can see a patient. And they want to try and get an answer. So, of course, they turn to a patient and ask the person, what brought you here today? What kind of problem can I help you with? And so there's only so much time that you have to convey that information. And I've seen so many people over the years waste that time saying things that are not relevant. Of course, patients don't always know what's relevant or not relevant. And the statistics that we have on people are that doctors interrupt their patients like in a ridiculously short period of time, within 1 to 2 minutes, instead of kind of listening to them tell their story, teach about history, taking a history and physical, say, the patients will tell you what's going on if you just listen. But young doctors and doctors in emergency departments, doctors in medical clinics, they have a chart to fill out. Some of them have, like, I have read 150 things that they have to check off in a visit. When was your last tetanus shot? All this stuff. And we have to get through it and figure out what's going on and decide what tests you need, be empathetic about it, and try to figure out how you're going to wrap it up and get you out of the department or get admitted to the hospital. So it's a lot. And to take shortcuts, doctors have something called heuristics. That means people get kind of placed in various categories. Part of the categories that people place themselves into are when they come in announcing what they think they have already. They've gone to WebMD or that's a good website, don't get me wrong, but it's not the same as a history and physical and diagnosis by a highly trained physician. And they're convinced that they have something. And that or some words appear on their chart from somewhere else. Someone has written words on their chart like non-compliant. So sometimes patients are starting out with their nurses and doctors having a bias against them. They're being given some sort of diagnosis, or it could be the words that they've used at triage that are placed on a triage note that is actually causing some non-curiosity in by their physicians. If the physicians and nurses think they already know what's going on with you, they're going to stop asking questions to find out what really is going on with you.
Would you put that in a category of patient profiling at all? In the negative sense?
Yes, I think that term, it's not, like all humans, the nurses and physicians tend to rush to a little bit of judgment based on what they have. When a patient comes in and says, for example, my throat hurts, I've got fever and chills, and I swallow, we're, looking for do you have a strep throat versus a viral illness type of diagnosis. And we're not even thinking about maybe the 10 other things it could be. We're looking for the most common things are still most common. I think this is why people tend to get pushed into certain diagnoses rather quickly. And part of the approach is to make sure you don't have the worst possible thing, make sure you don't have the zebra. Everybody understands that concept. Or the most life-threatening concept, because those are things we have to act on immediately. And then we order the tests and try to go through some kind of decision-making tree in our minds. And we come up with our working diagnosis. Now, sometimes when a patient finds out later that was incorrect, they'll use the term that the doctors were gaslighting them. I understand how that term is being used now. I think it's being misused a little bit. People are not being told these things in a malicious way. They are simply being given the wrong diagnosis because the doctor treating them at the time believed that to be true. Some conditions don't express themselves fully within the first visit or the first emergency department visit or or doctor visit or right away. Everyone who has, for example, appendicitis is fairly a common problem that people have. Everybody comes in with a bellyache. And, there are a lot of other causes of bellyaches that have to be kind of excluded before someone is taken to the operating room to have their appendix removed.
I was reading an article from the Scientific American about this term gaslighting. And the way they had defined it is medical gaslighting refers to cases in which a healthcare practitioner imposes a pattern of questions, testing, or diagnosis that runs counter to the history or symptoms the patient is describing or experiencing. There is usually a clear power imbalance at play. More often than not, gaslit patients are women, members of the LGBTQ community, people of color, and older adults. In many ways, the term gaslighting is an apt fit for medical settings, especially when it comes to the common refrain, "It's all in your head." So how do you respond to that, doctor?
I agree with a lot of that definition. I think that the kind of what is described as gaslighting in that definition does definitely happen to people who are more in marginalized communities. And there is a power imbalance because the doctors hold the power in the relationship. In response to the part about it's all in your head, I doubt that most doctors or nurses say that to their patients. This is what patients think that they might be hearing. And my response to that is pain is a sensation that is experienced or interpreted through your brain. So, of course, what's happening in your brain and with your emotions has a tremendous effect on how you experience pain. Which troubles me is that I think that some physicians don't communicate well about the point that they're at in making a diagnosis. What I wish those people would say instead is, here's what I have done. Here's the testing that I have done. And I did it to rule out diagnoses A, B, and C. Good news, I didn't find A, B, and C because A, B, and C are terrible. And I haven't found anything else yet. Follow up with your primary care provider or a certain specialist, and I will give you that person's name when the nurses discharge you at the end of your emergency department visit. But I think that some of our colleagues are not so great at that communication skill and will say, I can't find anything, so there must not be anything. And we know from other places in our literature that there are some people with difficult diagnoses, some of your listeners who have conditions that take a very long time and are very hard to diagnose. And part of the diagnosis of one of those, so I'm not that kind of physician, so I don't pretend to be an expert, is to exclude everything else. It's what we call a diagnosis of exclusion. I think that takes time. And I think to look back and say that doctor who saw me for 3 hours in the emergency department back in December was gaslighting me. I understand why people feel that way, but I don't think it's exactly true. So, but like I said, I wish that kind of uncertainty would be communicated in this way, like I haven't found anything yet.
Or even some of the podcast guests that I've had on the show, patients, have said, well, I walked away feeling like the doctor didn't believe me that I was experiencing these symptoms. What happens in that scenario? How would you say a physician reframe the thinking there?
Well, I do think that physicians need to push their computers aside, with their patients, sit down with them, and try to have a conversation where at least the person feels like they were listened to. Now, I'm going to give an example. When someone would come in, and we know that the brain, the motor function of the brain is controlled on one side, and there's a crossover, and the expression is on the other side. In other words, if you have some sort of stroke in the middle cerebral artery on your right side, it affects the left side of your body. So when someone comes and tries to present to me some symptoms that don't make sense anatomically, I know that it can't be that problem. That makes sense. You kind of work backwards, that it's got to be something else. There may be something overlying, and more than one thing can happen at the same time. And patients have, in their experience, and it's a simple experience, they think because one thing happened at the same time as another, that A happened at the same time as B, that A caused B. It's what I call, they think one thing caused the other, and it's actually correlation and not causation. And it's very hard to figure out because it seems so obvious to the person who has it. So I think that physicians have to kind of acknowledge that you had that. And bear in mind, everybody has different pain reaction. I mean, some people can sit there, put out their arm, and let someone start an IV and doesn't look like anything happened to them. And that the person in the room next door is screaming and crying in pain just from an IV start. And so we know that people's experience of a modest amount of pain is different. We have to figure that all into our calculus of how to interact with our patients who seem to be really sensitive to everything.
Yeah. And just to stay along the lines of your emergency room experience, and I'd like to go down a track for just a few minutes. We hear a lot that a woman's heart attack symptoms are very different or present very differently than a man's symptoms. And there's plenty of examples out there that a woman came in with maybe a little bit of chest pain, but not really, nothing crazy, but she knows something's not right. Maybe she's a little fatigued, but nothing blaring, but she knows there's something wrong. And she walks away with a prescription for, let's say it's an antacid because somebody said it was probably heartburn. I don't know. I'm making that up. You would know more than I would. But when you hear those examples and then come to find out that she was really having a heart attack, is that an example of gaslighting, would you say? How would you kind of define a situation like that?
Well, it's a complicated situation. That particular example, chest pain, very common symptom that people come to the emergency department with. Some of the classic studies in chest pain, how to treat chest pain, were all done in men. And the main reason for this was up until very recently, women were excluded from studies because that there was this fear that something with their hormonal cycles or pregnancies could not be included and would take them out of the study. So this change, just to even get women into evidence-based research, has taken a long time. Women, I mean, if you look on the age demographics on this, young women and younger women don't have as much coronary artery disease. And so when a young woman comes in and has chest pain, those aren't the first thoughts. Now, sometime in the 1980s, there were some regulations put in place by the governing bodies in healthcare in our country that said that we need to identify acute myocardial infarction, that's heart attack, as quickly as possible and get people, because we have really good treatment for that, to get people to the cath lab within an hour. And if you know anything about what happens in an emergency department, that's a big ask.
Yeah, because time is muscle, as they say.
Time is muscle, exactly. And, just to even get someone to the triage desk quickly, because of those rules, anybody, men, women, whoever, with any sort of chest pain, any sort of pain that occurs between, like their belly button and their chin, gets an EKG now. So we can tell whether there's acute MI or any kind of abnormalities on an EKG. So those are being looked at. If it's normal, it doesn't mean that a young woman, still can't have something going on with their cardiovascular system or something going on with the kind of rhythm of their heart. But we have more time to work those out. We don't have to get them to the cath lab in an hour.
Mm-hmm.
We can have these problems looked at and refer them back to a primary care provider. Now, what I think happens now, and I've read it even in the book by Dr. Sanders, which I recommend to everybody.
Yep.
Every patient
Lisa,
story.
Dr. Lisa Sanders.
Lisa Sanders,
Yep.
who, she was the medical advisor. She's on the staff at Yale and writes about difficult diagnoses. So maybe some of your listeners are familiar with her, that some young man who had chest pain, his diagnosis was missed in the emergency department. I'll take that hit. It's true. His diagnosis was missed, but I don't think it was just delayed. So people are very uncomfortable with that. It would be really great to have an accurate diagnosis made within, say, an average emergency department visit is between 4 and 6 hours, probably longer now. But that isn't possible for everybody. We're really, really good at diagnoses, but we cannot make an accurate diagnosis in everybody.
Yeah, it's a tough thing, especially when you've got other things running through the emergency department, broken bones and car accidents. And then certainly the things that are more what I'll call benign, like that sore throat or whatever it might be. And that we could have a whole nother conversation, which is reflective on the system where patients can't get in to see their doctors, their primary care physicians. So what is the other alternative? And typically it falls down to the emergency department.
Well, I understand why people are there. Our doors are always open. And when people are having a problem, we can address it. However, I read all the stuff on social media like you do. And, somebody, just yesterday, someone complaining about having to wait 10 hours to be seen for something, his hands being swollen. I'm going like, in my mind, I'm thinking, dude, your hands are swollen. That lady over there is having a heart attack. That child just had a seizure. That's why you're waiting for 10 hours. It's not an emergency. So it's when you're the patient, I get it. It's hard and it's a terrible day that you're having. But there will be a day when you're that person who's being rushed back and all the people in the emergency department are giving you the attention. And that's the way it works. To triage is from the French word to sort. And we're trying to figure out who's the sickest, who needs the most attention. It is not an unlimited resource.
So how do you think patients can kind of adjust their expectations to get what they're getting from their doctors or to get more from their doctor visits? Because it sounds like there's a lot of expectation management that needs to happen. It sounds like on both sides, but if we talk about patients, what do we as patients need to reframe in our heads when it comes to these interactions with our physicians?
Well, I think part of the expectations certainly when people come to the emergency department, perhaps not so much if people have some sort of long established relationship with a primary care provider or specialist, is to kind of not judge success by cure, but to have some other kind of functional benchmarks that we use to see how they're doing. Can you still go to work? Can you still get up and take a walk down the block? Those sort of things. It may be really frustrating if once you were a runner and you could go out and run 3 miles and now you can only walk up and down your block. But those are the kind of reframing exercises that we have to do to keep progress in mind. We sometimes ask people, are you better? And, whether you're using a pain scale or some sort of other benchmark, people are better, but they're still unhappy or not satisfied because they're not cured. So I think these are really tough. We're only humans. The patients are certainly human. Their family members are human and can be really disappointed. And frustrated on the other side.
Well, let me ask you this. I always like to ask this question to my physician guests as well. What would you say keeps physicians up at night?
Oh, that's a great question.
Mhm.
I think that uh, we are very perfectionistic type of people in general. Our profession, we'd all like to be perfect, and we strive for perfection. I read the definition of that once is basically that you just see your imperfections more clearly or better. So I feel that physicians would like to feel at the end of the day that they've done all they can to try and get their patient to a diagnosis, get their patient feeling better, and done all that they need to do. Now, in order to do that, I write about this in the book, which is kind of like a self-help book for clinicians.
I see that. I see that.
They
We're
have
going
to
to
feel
talk about
confident.
some of that. Yeah.
A physician has to feel, or a nurse, if you're in your position, has to feel confident in what they're doing. Not that that they know everything, but when I feel confident enough to know that I think you don't have these 3 terrible or 4 terrible things. I'm not certain about the other things you might have. I'm going to do more research on it. I know one of my colleagues may have the answers. So I'm going to send you to see him or her. If I don't know how to do a procedure, I know who to ask who can do it. Because there is a lot being asked of emergency physicians and primary care providers. We don't always have the right equipment to do certain things. We don't even have the ability in the emergency department to order the tests that would be apropos for a certain condition. I'm just going to use, for example, say someone has some sort of rheumatologic condition, some sort of autoimmune disease. Emergency physicians can't even order some of those tests. Part of it has to do with who's expected to follow up. And since we don't really have that ability, it's supposed to be a kind of one time and a one and done situation. We don't order testing or do a lot of things that we can't follow up on. Back in the day, the early days of HIV, for example, a lot of people needed HIV testing. We would not do it in the emergency department because we had no ability to kind of, and at the very beginning, those results were devastating. We had no way to do the counseling and follow up on the treatment. So we just wouldn't order them.
Mm. I don't think doctors get into medicine because they don't want to help people, obviously. But I don't know that patients understand the full extent of why a physician's hands might be tied. Uh, just kind of going off of what you said, just using the HIV example, but there's so many other things I think these days too that impede patients from getting the care that they expect just because they don't understand what is going on in the background. So if you weren't allowed to write tests because the hospital doesn't have the support services to follow up with this patient, this HIV patient, then you do the test and then what? What can you do for a patient like this? What are some of the other things that you think impede patients from getting a diagnosis, or really more so doctors being able to fully go down that path?
I think that there's a certain toolbox physicians in different offices or the emergency department have. I was trying to think of a good example for your listeners, and I would say that something like if you know that one of your kids threw one of their stuffed animals down the toilet, and you know that what you need is one of those gizmos, we call it a snake, to go down there and grab the thing and pull it out, to go all the way down there. And then you call a carpenter to come to your house. And carpenters have all sorts of cool tools that they can do, but they don't carry a snake. They don't do plumbing problems. So I think people are going to the wrong doctors sometimes. That's why I have had over my career people who keep on coming back to the emergency department. I understand why. We're the only people who can see them quickly. And we can give them something for pain or whatever the discomfort is, or if they're nauseous or if they're dehydrated. We can treat the symptoms, but there's only so much we can do about the workup and following up in that way, or some of the treatments. It's a challenge sometimes to get to the right professional. I do understand that. And it is frustrating, and particularly now, I think things have gotten worse since COVID, about getting on the docket for some specialist or some sort of procedure, and you're told, like, well, the next appointment's in 3 months. My husband is gastroenterologist, so I hear a lot of these stories about his patients. So someone will get a Cologuard test, which is the stool DNA test, and say it's positive. So, nothing worse than your doctor saying you have positive tests and you might have cancer. And so you call them back and they say, okay, the next appointment. And this is a person who's working at a scheduling desk who doesn't really understand the urgency of the issue. Will say, okay, I'll make an appointment for you, in December, and it's July. And like, well, I'm not going to, that's intolerable. And there has to be a way for people to work with the system getting quicker. And let me tell you, I'm a physician. I have problems with the system as well. I mean, I am dealing with a health issue myself. And even though I have the physician's cell phone number, I still have issues. So it isn't easy. There's a lot going on. And I think the more, there are ways to communicate with the physician directly, whether it's through the patient chart, where patients can ask questions, and sometimes the physicians will see them directly, or the nursing staff through the office who can message the physicians. So, of course, the patients need to be their best advocate. They need to be polite, but firm and persistent. When you're that person who's angry and frustrated and yelling all the time, nobody wants to deal with you, and you get discharged or asked to leave the practice, and you don't want to be that person.
What I found interesting too, going back to your chapter 2 of what makes a good patient, and you write here, most healthcare workers would describe their ideal patients as independent, hardworking, and self-sufficient individuals who are logical and rational in their thinking. These individuals want to be helped, and they respond in a mature fashion to their doctors and care providers. They follow advice without overreacting or becoming overly emotional. Good patients recognize that the clinician has imparted wise advice based on training and experience. Not only are these the characteristics that most physicians expect in a good patient, but they also use these qualities to describe themselves. Thus, good patients are actually people who reflect what the physicians and nurses view in themselves as desirable characteristics. So there's a lot of, one, pressure, but two, self-imposed judgment, it seems, on the physician's part. Again, wanting to do good work, but a lot of self-imposed judgment here.
Yeah, I think physicians judge themselves harshly. They judge their patients very harshly. They judge them by how they react to their advice. That, again, I said about that kind of maturity, not being overly dramatic, all these things that they see in themselves. But when I talk to physician groups about this part of that slide, I talk about where our biases come in. And there are a lot of them. And any bias, or when a white patient is when a white doctor is treating a Black patient, when a patient is treating an overweight, and when a doctor is treating an overweight patient, there are a lot of biases. If someone who doesn't understand why people wear their hair a certain way, and that person comes in that way, they don't like all their body ink, the whole thing, there's so much judgment going on. It gets in the way of how that person is viewed, how their symptoms are interpreted. Are are they being overly dramatic, or are they overreacting? So there's a lot to cut through. And my message in the book, just to be clear, because maybe haven't made that clear, is that there are no difficult patients. Patients are not difficult. There are just some challenging interactions with people, and doctors and nurses and physical therapists and paramedics need to work a little harder to try to accept people as they are. And once we do that, we can get and actually even love them, respect them, have empathy for them, have more curiosity, lean in harder, and find out what's really going on with them. That's the message of my book. And so that's what I want to be clear on.
Yeah, definitely. Thank you for clarifying that for us. And the empathy part of it, I think we all could talk about physicians that, you could tolerate a physician that's really, really nice and they're trying hard to find answers for you. Might take a little longer, or maybe you're not getting anywhere really with that physician, but the physician is at least a good listener and has shown some level of empathy, et cetera. And then there's the doctors who, and again, from a consumer standpoint, we'll talk about patients as consumers because we are consumers and, shopping for our doctors and where we want to have treatment. So we do have choice on where we go for most of us. Some don't, but you hear things like, oh, my doctor's so nice and he or she really listens really well, but I haven't really been able to figure out what's going on, but I worry about moving on because I'm so loyal to this doctor. And there's this kind of this guilt factor of moving on to another provider. How do you think providers look at that? How do physicians look at that when a patient wants to move on?
Sadly, I think doctors take that quite personally.
Mm.
They're insulted when patients ask for a second opinion because they interpret that as saying, you think I've made the wrong diagnosis. You think that I'm not well trained. You don't trust me. You don't really believe me. And patients look at it as something very benign, which is, no, I just want a second opinion. I want to see what someone else thinks. So I would say, don't be surprised when you say you want that the first person just kind of shuts it down, like, okay, bye. So that is an interesting phenomenon that I see, and I hear my husband express it in some of his patients. But what I try to gently remind him is that the people are a little bit discouraged and hoping that they're going to go somewhere else and find an answer that they like better. And the kind of doctor shopping phenomenon that we see. Now, sometimes it's absolutely reasonable because you need to hear different approaches and what therapies are offered by different people, slightly in different niches of the profession. So, but I would not be surprised to find that the original doctor might be a little bit insulted by that.
Yeah. Yep. I actually had a situation like that where I was having problems with tinnitus or tinnitus, however you prefer to pronounce it, ringing in my ear. And I had gone to my long-standing ENT, loved her to death, always asks, how is my mom? All these nice things. And she's done well by me. But then I had this ear ringing problem and I had a hearing test and she said everything was fine. And there's nothing indicating as to why I would have ringing. And it was kind of a just live with it kind of scenario. I didn't take no for an answer at that point and went on to another physician who did a CT of my sinuses and that still came out okay. But I was still experiencing things like a lot of sloshing in my ears and pressure in my sinuses and in my face. And so I had to go to ENT number 3, who said after having the hearing test, the CT, and my primary actually told me to get an MRI of my brain, which was scary, which made things scary because I'm thinking, holy cow, what could be going on that's causing this earring? What is so terrible in my brain that we need to do a scan, but okay. And ENT number 3 gave me another hearing test. She gave me a pressure test and she said, you have a pressure problem. And that's what my gut told me initially. That's what it was. But I kept going. And after a few weeks of steroids and all kinds of nasal sprays, it's been gone for 4 months now. So sometimes you do have to push enough to where either every option is exhausted, or you accept it is what it is and you do live with it, or you eventually find someone who has the answer. But what do you say to patients who have, say, for years, have been going down the path of trying to find resolution for symptoms or a name for their symptoms, or maybe they were even misdiagnosed? At what point would you advise a patient to, they say acceptance is a beautiful thing, but accept where they are, and that's kind of it. That's where they're at.
Well, I think it's difficult for people. I understand. There was a reason I went to the kind of medicine that I did. I wanted that kind of excitement and things that were, there's nothing better than having somebody with an acute problem and you turn them around during their time in the emergency department and they look kind of on death's doorstep and they like walk out. I mean, there really is no better feeling in the world.
No.
So the people who are not getting that, I know it's frustrating. I think that I think more emphasis needs to be put on how they are functioning, how they are improving, what kind of therapies they can use and feel more empowerment, and maybe not a cure or maybe not the proper diagnosis, but working on the symptoms, I think is very helpful. I used to tell people when they came into the emergency department, I'm going to make you feel better. I may not be able to tell you exactly what you have, but by the end of here, you're going to feel better. And there's usually something in my bag of tricks that I could use, even if it was just a warm blanket and a sandwich.
Well,
There's something to be said for that.
no.
So I feel I empathize entirely with some of your patients who are going to listen to me and think that I'm full of shit. But it is definitely a challenge. And I think that we need to kind of look at our own lives and learn to accept some things. Some of us are dealt terrible hands. And some people are living in victim mentality and looking for the doctors to be the villain who didn't diagnose them soon enough or didn't quickly enough or didn't find the answer soon enough. Believe me, your doctors really want to find the answer as quickly as possible.
Yeah. Well, we know that physicians are working up against so many different barriers as well, between insurance, and you only get so much time with a patient, and staffing issues and all these things. And not that those are excuses by any means, but for me, hosting this podcast, it was really important for me to really bring the point around that doctors are doing their best. They do want to help you find answers. Sometimes there are roadblocks. Some can be busted and some can't. But I think your perspective, Dr. Naidorf, has been so enlightening and illuminating, and maybe patients can be a little more gentle when it comes to judgment on their physicians as well. But of course, we're also in a immediate gratification society too these days, and we just want the pill that will fix everything. And unfortunately, that's just not the case. But any other thoughts, doctor, that you'd like to make sure that our listeners are aware of, or any key concepts from your book that you'd like to bring out to all of us?
Well, the book is something that I think that people may find useful to try to help understand what some of the issues are going on in the minds of their physicians and nurses and other clinicians. But I think that it's very important for patients to kind of not be that difficult person and try to be non-confrontational, ask open questions, try to ask for explanations if you don't understand what's going on, not in a confrontational way, but perhaps you can explain to me, doctor, why you're ordering these tests or why you're ordering this medicine. What is your thinking behind it? And if it does or doesn't work, what will be our next step? And your physician should be able to answer that question without feeling threatened or challenged by it. And if they cannot, perhaps they're not the right person.
Mm.
So I'm not advocating shopping around, but I think there are various kind of models of physician-patient relationship, and the very traditional one has been what they call paternalistic for obvious reasons. Most of the physicians were originally men. I call it maternalistic for obvious reasons. I'm trying to do what's right for you as though you were one of my children. And I try to feel that way towards you. However, you might have a totally different life experience and not want something done that way. And what is the more modern and preferred way is for me to ask you what you want and try to come to some agreement on how we can do things better that kind of make you happier and I'm okay with. May not be my choice of how we do things, but I can still live with it. In the book, I call it all or nothing thinking. A lot of doctors get into that. So there are ways to make this better from the physician's perspective and from the patient's perspective. It does take communication. And the only way to have that is to have a little bit more grace, a little more kindness on both sides. I think that we can get there if we work at it.
Well, Dr. Naidorf, thank you so much for all of this wisdom, all of this wisdom that you've collected all these years in the emergency department and all your work on this book. It's just been, again, very enlightening for me and hopefully for all of my listeners as well. Again, Dr. Naidorf is the author of Changing How We Think About Difficult Patients, a guide for physicians and healthcare professionals. And like every other book out there, I got mine on Amazon. Are there any other places to get your book, Doctor?
Well, there's two or three other things I'd like to say quickly. First of all, some of the other writing I do on Medium, also on my blog post site, is about how patients can improve their experience and how to read their chart. I wrote something recently, which I kind of think everybody needs to read because patients and their families are reading charts and panicking. I've had an experience recently where I read my own chart and I knew enough to know that, holy cow, what are they writing there? And it is disconcerting. It made me anxious, and I know how to read the chart.
Yeah. Well, that's like lab results and test results are getting pushed out even before physicians are reviewing lab. And then you're looking up at least myself and other people I know, we're looking up all the words we don't know and putting the story together, and it's dismal. So when really it's nothing.
It's very challenging. And then to add another layer to the gaslighting story.
Yeah.
Patients are looking at those results and saying, why didn't my doctor tell me I have this problem?
Yeah.
And a lot of times the reason is because the doctor knows it's not really a problem, even though a radiologist had to write those words on the chart. And it is one of the things I write about so people can find out more on that. The book is available in a lot of different stores and storefronts. What I will tell people is that it's available as an electronic book as well. And it's also available as an audiobook on Amazon. It is a relatively short book. It's only, the running time is under 4 hours. Although I will say I don't know if you noticed the artwork in the book is really cool.
I did. Who did that?
The gentleman is an artist that the publicist.
People can see
I can't think of his name right off the top of my head, but it's in there. The credits are on that. And the book is narrated by a professional voice actor, a lady. You do not have to hear my sweet New Jersey accent.
I hardly hear. I'm not picking up on that at all.
But I think it takes a professional, like so many things in our world. Professionals do it better. I mean, there are obviously a few famous people out there who read their own books, but I'm not famous, and I want people to get the most out of it. If it takes listening to it on the way to and from work. One lovely emergency medicine resident told me that he read a chapter of it before every one of his shift as a little pick-me-up. As a little boost of confidence. So, or you can be like my dear sister who bought a copy. Of course, I gave my sister a copy that I signed, but she went out and bought a copy
Oh,
and read it and then gifted it to her physician.
oh, wow. Interesting. Wow. I wonder how what a doctor would think about that if their holiday gift was your book. They would be looking into that thinking, what are you trying to tell me?
I think everybody in every profession knows that there are always a few difficult interactions with people that are going to, what was otherwise a pretty good day is going to make it terrible.
Mm-hmm.
This book gives people some background on what's coming in on both sides and some tools to use to make it better. We still have a lot of problems in our healthcare system. The comments you made before are true.
Mm-hmm.
And we can't really do anything about some of those. This is something we can actually improve. So it's a little message I'm trying to get out there. If anybody knows anybody who's in a residency program or wants me to talk to them, I'm always happy to do that. I'm going to be traveling to New York City next month to talk to the staff at a children's rehab hospital. And I couldn't be more thrilled. I want to help those people do a better job and not to get down because one or two of their interactions go badly.
And those of us having worked in healthcare, patient satisfaction is a big metric for hospitals, and it is a metric based on how hospitals are paid by some plans and Medicare, Medicaid, et cetera. That's a big metric there, and those scores matter as far as hospital administration goes as well.
Those scores matter. They matter for the patients and that sort of aspect of it, but they matter because I want all the doctors and nurses to feel better about their profession so they'll stay in clinical medicine.
Yep.
Some of the headlines out there say, 1 in 4, 1 in 3 nurses and doctors want to leave the profession. Well, we need more doctors and nurses taking care of sick patients and staying in the profession and gaining the useful experience that will help us as we age. So that's why I'm doing what I'm doing. And I hope that people are getting some benefit from it.
Yeah, absolutely. Because I think I heard that there is something of a potential shortage, but also there are more women in medical school these days. So yay to all of that. All right, Dr. Naidorf, again, how can folks find you? What is your website?
The website is drjoannaidorf.com. And that has, in there has the links to some of the other things I'm doing. Some of the videos and podcasts that I've recorded are on there. Just kind of take care of all that social media myself, which is the work product of an older person. So it's maybe lags a little bit behind. I'm trying to make a difference, and hopefully we've helped some of your listeners.
Yeah, well, I do believe that it will. And again, everyone, Joan Naidorf, Changing How We Think About Difficult Patients, a guide for physicians and healthcare professionals. Everyone, thank you so much for listening. I hope this was enlightening for you. It sure was for me. I'm your host, Laura Nozica. Thanks for listening. Stay well and keep pushing for answers.
Oh my goodness, that's a wrap on another compelling story. Thanks for listening to the Desperate for a Diagnosis podcast. If you would like more information about today's guests or to find out more about Laura, go to desperateforadiagnosis.com. If you enjoyed the show, please subscribe, rate, and review the podcast on Apple Podcasts, Spotify, YouTube, or wherever you get your podcasts. You can also follow show updates and healthcare news on the podcast's Facebook page. If you would like to be a guest on the show, or if you have any questions, advice, or suggestions for our guests, please email me at lauramarie@desperateforadiagnosis.com. Please note, I am not a medical professional, nor am I affiliated with any healthcare, pharmaceutical, or device company. I am an entrepreneur and an independent market researcher focused on helping healthcare organizations better understand the patient perspective. The podcast is not meant to offer medical advice, but to merely share the stories and perspectives of podcast guests.